Well, I'm just going to talk a couple of minutes on the non-surgical treatment of the stiff elbow, both on the problems relating to elbow soft tissue contracture and on heterotopic ossification. Oops. Ectopic bone formation are seen of two different types, myositis ossificans and the heterotopic ossification, which is the one I'm going to talk about, HO. And there is also heterotopic calcification, which we see as calcified deposits, typically in the ligament, but it's not true bone formation. The mechanisms of heterotopic ossification is migration into the injured area of pleomorphic cells, and the proliferation of these cells, the multiplication of those cells, and later the differentiation of these cells into bone-forming cells. And these different steps are amenable to treatment. So the first two different steps can be touched with NSAIDs, or the two later steps can be reached with radiation. The diagnosis, Lars has touched on this, is of course restricted range of motion, X-rays showing heterotopic ossification, and sometimes a rise in the alkaline phosphatases. This is not typically seen in the elbow because it's such a small joint. It's more likely to be seen when you have HO around the hip. And treatment of HO consists of prevention and excision. And prevention, when do we sort of take preventive measures? It has to do with the fracture, and the more severe the fracture is, the more should be on guard and take preventive measures, particularly if the radial head is involved in the injury. And also with burn patients, and with any patient that has had previous HO, because they are likely to again form heterotopic ossification. And prevention has a couple of different steps. Surgery, Lars talked about that, anti-inflammatory agents, and gamma radiation. Surgery comes down to a gentle technique, removal of all bone debris, sealing raw surfaces, and surgical timing. And perhaps this was the article you sort of thought of. They looked at the degree of or rate of heterotopic ossification if the patient was operated within 48 hours after the trauma or after 48 hours after the trauma. And none of the patients operated in the early phase had HO, whereas 8 out of 24, that is 30%, developed HO when they were operated after 2 days. What we know about the preventive effect of NSAIDs on HO mostly is derived from what we know from the hip. So these data are more or less just extrapolated into the use of the elbow. And the typical treatment consists of 100 milligrams of indomethacin daily for 6 weeks post-op, paired with mucoprotection for the tummy. And of course, in the fracture situation, people may feel reluctant to use these drugs because they may interfere with the healing of the fracture. We haven't got enough data on this. When it comes to gamma radiation, the same applies. What we know from the hip, but there are a few reports on the use of the gamma radiation in the elbow. Most of the reports today have the same sort of protocol. They use 700 centigrays given as a single dose in a specified field on the elbow within 72 hours post-surgery. It's said to be a safe procedure, and no secondary sarcomas have developed in doses lower than 3,000 centigrays. So 700 centigrade seemed to be safe. The reports have been on surgery for heterotopic ossification. None out of 9 had recurrence of heterotopic ossification once it was removed and had gamma radiation. In another recent article, 3 of 26 had recurrence after removal of HO. And mind you, these are the patients who have sort of defined themselves as being HO-forming patients. So this seems to be sort of pretty promising data. When it comes to fracture surgery, there's an article a few years ago showing that 10 out of 11 receiving gamma radiation post-fracture surgery had no symptoms of HO. Excision. Lars talked about that. Why? When it interferes with range of motion. There's a classification specific for the elbow made by Hastings some 10 years ago. 3 groups or classes. Class 1, no functional limitation. Of course, surgery is not necessary, but you should be aware that these patients are potential HO formers in another trauma situation. Group 2, they have a partial limitation in the range of motion, either in flexion extension or in pronation supination or combined, and 3 is ankylosed elbow. Excision should be carried out first when it's mature, which means typically 6 to 12 months after the injury, and when the elbow is not angry anymore. It can be perhaps defined as the HO having some sort of outline on the X-ray films and the alkaline phosphatases if high has gone down. And removal of HO should be combined with prevention, as HO is a strong predictor of recurrence. And you can also expect a larger improvement in range of motion after HO excision than after just a contractile release in the patient who doesn't have HO. Because HO, if it's restricting to motion, it's a sort of bone block that you remove, and these patients go with better results. The non-surgical treatment of manipulation, of continuous passive motion or splinting. CPM, a recent article, showed no effect. It's a cohort study, so 16 patients were operated with elbow release with CPM as a post-op measure, as 16 patients were operated with CPM as a post-op measure. And with these 32 patients, they couldn't detect any differences with the use of CPM. When it comes to manipulation, there's a recent article from the Mayo Group who says that out of 51 patients who had the manipulation 40 days post-op, they could improve the range of motion from an arc of 40 degrees up to 78 degrees. But they are emphasizing that it's not a manipulation, it's not a forceful manipulation. They rather call it examination under anesthesia. So they are very gentle. Because as Lars pointed out, it's a very risky procedure to do manipulation on anesthesia. You can cause new fractures. You can certainly cause aggravation if you try to use any force. And it's also well known that you can cause heterotopic ossification by passive manipulation. So we never use it. This is a recent article. I don't know if it's going to be followed by others, of course. What seems to be a viable option for treatment is a non-surgical treatment, and it has certainly survived. This picture is from 1517, some 500 years ago, and it's a turnbuckle splint. They look very much the same today. Splinting seems to be effective in the early phases of disease, that is up to 6, 7, 8 months after the injury. whenever you don't have any osseous or articular restriction to the range of motion, because what you are striving after with splinting is, of course, stretching of the soft tissues. It could be delivered as either static or dynamic splinting. Whatever you do is you should avoid pain, you should avoid swelling caused by your treatment. Splinting could also be used as a means of avoiding swelling post-op by just putting the elbow in a straight position rather than in a flexed position immediately post-op. This is the main article on turnbuckle splinting, cited by most authors in the field 10 years ago. They started with the splinting procedure or splinting regime about 2 to 7 months after the index operation. The patient had used the splint for 20 hours per day, up to 4 months. And they switched the splint from being an extension splint to being a flexion splint, so it could sort of work both ways. And they seemed to gain about 30 degrees of motion from what they had when they started, 32 to 108 to 26 to 127. Instead of having a turnbuckle splint, you can use, of course, progressive static splinting. That is just a static splint that you remake or adjust at regular intervals to make it straighter or more flexed, depending on the situation. And the results are much the same as with Gelinas, and this is from the Boston group, Dornberg et al. So to conclude, prevention, don't hesitate to use prevention. We use radiation with these complex patients that are likely to form HO, and you can of course use NSAIDs in selected cases. Splinting is effective when properly used, but don't use it to inflict additional trauma. And this is just a patient case to conclude with. This is a late release done in a 48-year-old lady who sustained a fracture in her childhood. So she was presented to us 40 years after the trauma and had 90 degrees of flexion contracture. And she was unhappy with that because she started to get shoulder pain and back pain. And of course she had a combination of extrinsic contracture from the soft tissues around the joint and also intrinsic contracture from the joint deformity. So what we did was a lateral column procedure, and we took down the lateral collateral ligament to be able to reach fully around the lateral column. We removed the bony spurs and removed the soft tissue, the capsule. And post-recovery period, she gained significant extension, so she had an extension deficit of only 40 degrees, and she was extremely happy with that. These are sort of difficult procedures because if you do a too extensive release, you will have problems with a deranged joint like that, and you will provoke arthritis of the joint. Okay, thank you very much.